Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clearwax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have a patient who attended with left-sided otitis externa. To give you a case history, I actually saw this patient 3 months ago. I'll come back to that in a moment, however. Now, as you can see, as I was entering this patient's ear canal, the ear canal itself was collapsing upon itself, and that's because of all the edema, the swelling. So all these cells lining the ear canal, they're full of fluid, and when I'm suctioning, the fluid inside the cells is getting attracted by the suction power, so hence why it's collapsing upon itself, which meant I wasn't able to use the full Zollner suction probe for this procedure. I had to use the fine end, which can make it a bit more tricky because you have less suction power, and it's going to take just obviously a lot longer. But there was no way I was able to enter with the full suction probe. Even with the fine end, there was occasions where the canal collapsed upon itself. And I think midway through, you will see it. I decided to try and put a speculum in here to try and keep this ear canal open so I can then put the full Zollner suction probe in. But you couldn't even set the speculum inside the ear, given how narrow it was. So it was quite a complex procedure for that case. But going back to the case history, this patient attended about 3 months ago, and obviously the ear was in the same state. So I cleared out all the debris, obviously the inflammation was there, and I wrote to their doctor and explained that this patient's got an infection. I would recommend a swab just to see whether it's a fungal or bacterial infection, and thereafter they need to be prescribed the appropriate medication. So this patient attended a couple of days ago, so I asked them how their appointment went, and they said they saw a nurse and the ear wasn't infected. So initially I kind of felt maybe it was because I cleared all the debris and the ear didn't look infected, but the inflammation was still present, and there is going to be some residual discharge still that I'm not able to remove. With an infection like this, you'll see it a bit later on near the eardrum. It's just physically impossible for me to remove all the debris. So there should have been those signs there that the infection is still present. And also I've written a letter, so I've advised that there is an infection. So they were basically discharged, and lo and behold, the infection's come back. So we've written to the GP again, just requesting that this patient does need some attention, because in a short space of time, 3 months, the infection has returned, and you can see here all this debris. Now, what we don't know whether this is a bacterial or fungal infection. So this patient does have a chronic history of otitis externa, which is an umbrella term given to an infection or inflammation of the outer ear. And in chronic cases, they're typically more fungal. So the majority of outer ear infections are bacterial. I would say it's 70 to 80%, whereas the other 20% is more fungal. You can actually get viral infections of the ear canal. It's called Ramsay-Hunt syndrome. It's when you have shingles of the facial nerve. So the facial nerve runs in the inner part of the ear canal and also through the eardrum. And then there's a branch of the facial nerve that runs on the back top part of the ear canal. I'll come back to that, but you would have just seen I tried to put the speculum in, but it wasn't going to fit into that gap. So momentarily I've gone back to the full Zollner suction probe because I needed that additional power, but I just couldn't get it in. The canal will just collapse. And when you have shingles of the facial nerve, because the facial nerve runs at the back top portion of your ear canal, you can develop a red vesicular rash, which also then you can see the rash on the bowl of the outer ear, because that part of the ear is also innervated by that branch of the facial nerve. So yeah, you can get bacterial, fungal and viral infections of the ear canal. I just suspect this is more fungal, just because of the consistency of it. It's more thick and creamy, it's on the eardrum. Fungal infections really enjoy inhabiting deep in the ear canal where it's warmer. Now, our ears are full of bacteria and fungi, and these under normal conditions are non-pathogenic. So they live there harmlessly. They seek shelter and food from the ear canal. And the ear canal itself doesn't really benefit from their existence per se, although you could argue having these healthy bacteria and fungi kind of outcompete any potential pathogenic bacteria or fungi that may enter the ear. So in that sense, the literature states it doesn't have, the ear canal doesn't benefit, but I suspect there is some benefit for the ear canal as well. But when the conditions of the ear change, then it can lead to an infection. So the main conditions that we want our ears to be in is dry. We don't want any moisture in there. We want the pH level to be mildly acidic. The pH is more related to bacteria. So the bacteria that reside in the ear canal, so the natural resident bacteria, which forms part of the natural microbiome or the skin flora, they are acidophilic. So they thrive in more acidic conditions, but they're non-pathogenic. But when the pH level increases, you can get more neutrophilic bacteria, so bacteria that prefer and thrive and exponentially grow and reproduce in neutral conditions. Moisture, so going back to water, so moisture favours both bacteria and fungi. They love the humidity in the ear, provides a perfect incubation environment for them. And also the other important factor is temperature. So if you have increased temperature in the ear canal, again, these can affect both bacteria and fungi. So when one of these conditions is compromised, so the pH level, the moisture, humidity and temperature, it can give an opportunity for pathogenic bacteria to enter the ear, or the fungus that we've already got in the ear to overgrow. And when they overgrow, they activate the immune system, so we get inflammation. When you get inflammation, you get more dead skin formation in the ear, which then the fungi can further grow and feed off. And typically with fungal infections, as I said, they go deep in the ear. You get these thick layers of skin that I'm peeling away right here. So not to say it's not a bacterial infection, sometimes it can coexist as well. I've known cases where a patient has had both bacterial and fungal infections. Although there's one, I forget the name, but there's one fungus and one pathogenic bacteria which actually compete against one another. So in other words, you won't see both that pathogenic bacteria and fungus in an ear. It's one or the other. They do compete against one another. So yeah, it's a really, really difficult case because of how narrow the outer half of the ear canal is, and also the consistency. Now, I wanted to avoid putting any drops in, but I had no choice. So I've had to use some sodium bicarbonate drops as well, because olive oil wouldn't work with this. Obviously, we're suctioning straight away, so we're getting away a lot of this dampness. And I've asked this patient to use some acetic acid spray prior to getting an appointment with the doctor, just to reacidify the ear, because sodium bicarbonate drops is slightly alkaline, unfortunately. But sometimes you have to weigh up the pros and cons of using drops and not using drops. And in this situation, I just felt it was necessary. So hopefully they can have a swab ASAP and get the right treatment. So I can see some of the eardrum, not all of it, and I'm going to spend some time now just peeling away some of this infected dead skin that's lining the ear canal. What was more complex a bit later on in the procedure is when I'm removing wax directly off the eardrum, particularly the anterior recess. So as we approach the eardrum, the ear canal narrows and then it widens. And it widens more on the front part of the ear canal, so in the case of the left ear on the left-hand side, and it creates a little pocket, a recess, where you can get debris collection there. And also it widens at the floor of the ear canal, so you get an inferior recess, like a trench or basin, if you like. And it was the physics of it all. It was just so difficult getting the suction tube into that angle. It just physically was almost impossible. I did get the majority, there's a bit left behind, but I just wasn't able to do it. So hopefully this patient is going to get their medication ASAP. So the argument would be then, would you use irrigation to get that last bit? And no, I would not use any water in this patient. I know I've used some drops, but it's sparingly. In cases of otitis externa, using water is contraindicated. You shouldn't be using it in the first place. Now, sodium bicarbonate drops has got some, because of its effervescence, so sodium bicarbonate drops, let me get this correct, it reacts with a carboxylic acid, which is produced by bacteria that feed on sebum. So sebum is an oily lipid secretion secreted by the sebaceous glands, and you find sebum on most parts of your body where there's hair follicles, mainly the scalp, and you have bacteria feeding on that. Sebum itself, and also the outer layer of skin, the epidermal layer of skin, also has some carboxylic acid as well. So it's not only produced by bacteria feeding on the sebum, but there's some carboxylic acid already present on skin cells and also in sebum itself. So when you apply sodium bicarbonate drops into the ear, it reacts with this acid, and the sodium bicarbonate drops is converted into water and carbon dioxide. So when you get a liquid converted to a gas, you get this effervescence, you get this bubbling. That bubbling is said to have some kind of antiseptic properties. It can help kill some bacterial fungi because it can damage the cell membrane of them because of that bubbling action. So, I mean, there's an argument when you perform ear irrigation, why not use sodium bicarbonate drops as opposed to just normal water, which is typically what is the case. But again, you're gonna get that water, you're gonna get maceration of the skin will absorb, overhydrate, break down, so you break down the outer layer. So yeah, you can re-acidify the ear, you can put some acetic acid in, but the presence of water itself, now you can go in with trying to absorb a lot of that, which is the recommendation actually. If you are performing irrigation, the recommendation is post-irrigation, you actually try and absorb and dry up the ear. So you can there's different ways of doing that. You can do an oral toilet where basically you get some cotton wool, and so some of these instruments that we use, the Jobson horn or the Correct or the ear hook, I don't have them on mine, but on some traditional ones, on the opposite end you have a serrated tip where you can get some cotton wool, kind of you spin it around that, and you then go into the ear, and it's called dry mopping, sorry, and you spin it around. But when that can still be uncomfortable when you're into the ear and the ear's infected and you're applying pressure and you're swirling it around. I mean, I've had that done in my ear before and it is a bit painful, although I've got sensitive ears. Of course, as I said at the beginning, there's the ears, if the ear environment changes, it can obviously then lead to an infection. So the moisture, the alkalinity, so tap water in the UK is more neutral, if not even alkaline. If anything, saline water is probably going to be your best option. I think the concentration is 0.9% of salt. And at that concentration of salt, it's isotonic, so it's got a similar solvent to water concentration as the fluid that is not lining the outer layer of skin, but the deeper layers. So in the bony part of the ear canal though, you've only got the epidermis layer, which is full of keratin really, so there's not really much fluid in there. But with an isotonic solution, you're not gonna withdraw too much moisture, and the skin cells itself won't absorb too much moisture. So, I mean, there is going to be some moisture in the epithelial outer layer, the corneum stratum we call it. But also importantly, saline water is acidic. So I did a pH test on it. So it's acidic. So it has in that sense, it has its own antimicrobial properties for the ear. But it's just the water element. So I did discuss this with an ENT, and they said, well, if you're going to perform irrigation, then yeah, saline would probably be the best option compared to normal tap water. I mean, even sterile water, you may be sterile, but once you then transfer it into a syringe pipette, you can have bacteria almost immediately incubating that. So that's another possible way around, but yeah, you just wouldn't perform irrigation full stop to begin with. Now, you can see anteriorly there is a bit of redness there. Now, I did ask this patient if they've got any pulsatile tinnitus, because you've got to be wary of a Glomus tumor. So you, around some nerves, you have Glomus cells, which can then form into a tumor. and it can happen in the middle ear and also the jugular, the nerve, which kind of runs almost parallel to the back of the ear. And you can get this mass, we call it a glomus tumor. And quite often these can develop in the middle ear, and it can protrude outwards towards the eardrum, and it can cause pulsatile tinnitus because it has its own blood supply. So this patient doesn't have any pulsatile tinnitus, but you can see the front part of the eardrum is red now. That could also be subsequent to this chronic infection this patient's had for several months now. So that once this infection is cleared, we need to just re-examine the patient's eardrum just to make sure that's settled. I mean, I have asked the GP to refer to ENT, if truth be told, because it is a chronic infection that they're suffering from, and I think they'll benefit more from seeing an ENT. So I'm just trying to get as much debris out as possible. There's some skin here on the anterior canal wall. You can just see all the edema, the swelling there. There is some residual debris in the anterior, so I just physically just wasn't able to get in there. I did angle the fine end tip to try and get into that gap, but I just couldn't get in there. Even with the wax scope, I just wouldn't be able to, because of the speculum you saw earlier, I just wasn't able to get the speculum into the ear. So that would have been completely invisible if I was using head loops or even the wax scope. So one of the things that, when we first developed the endoscope, and I have told this story before, but unfortunately, I think it's just in the UK, I think it could be everywhere, but you have a straight status quo where people don't like innovation, they don't like new concepts. And obviously, myself and Clearwax at the time introduced the endoscopic approach. Now, endoscopic is not new. It's been used in the Far East for many, many years, and in Asian countries. But typically in endoscope, you have a separate monitor. So it's a wide system. So you're not looking at the patient, you're looking at the monitor. But obviously with the iClearScope, where you have the iPhone attached to the endoscope, it changed everything. And also the light source, so you have I'm just trying to grab one, but I didn't got one anywhere near me, but the handle of the iClearScope endoscope is also doubles up a light source. Historically, light sources were big boxes, they weren't portable, they weighed a ton, and you would plug that into the endoscope. So when we introduced endoscopic earwax removal into the UK, you have people obviously trying to discredit it, and there were some guidelines issued which got revoked later because of our response to them, myself and my ENT colleague, Mr Darius Rajali. And one of the things that they mentioned is that you can't perform endoscopic earwax removal in narrow ears. Well, you've got a video here of me doing it where I couldn't use a speculum, because if you're not using an endoscope, you're using a speculum and then looking through the speculum, either using the wax scope, which we just developed, head-worn microscopes, or an ENT operating microscope. But then, so obviously we questioned that, and the great thing about our technology is that we can take recordings, and so I supplied evidence on what you can. And in fact, I would argue, if you're skilled at using an endoscope, it's actually better to perform procedures in narrow ears. And I genuinely do believe that. If you know how to use an endoscope, you use the endoscope to stretch the ear, and you use the instrument to stretch the ear to go deeper. You can see the view we're getting from here, and considering how I couldn't get the speculum in, it's quite amazing that we're able to get this view. So yeah, and what was the other thing about what they said was, and then also in my response, I says, well, how is it the case that an endoscope can't be used for earwax removal, but it's been used for middle ear surgery? It just doesn't make sense. So you've got ENT surgeons using an endoscope to cut open the eardrum, enter the middle ear, doing really complex procedures. So yeah, you can see there's a bit left behind there. I do apologise for not removing that. I just physically couldn't get there. But I'm really pleased with that. I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.